process, curriculum, and then some of our outcomes. We've been doing this now for 20 years, so we do have some outcomes we can point to. The mission of our RMED program, the Rural Medical Education Program, is to admit and prepare medical students from the state of Illinois who will, upon completion of their residency training, locate and practice in rural Illinois as primary care doctors. Our admissions process, I want to say a little bit about what we've got on the slide here. We have a dual application process. All of our students, whether they're pharmacy students or medical students, have to apply through the national application procedure. For medical students, that's AMCAS. For pharmacy students, it's PharmCAS. But in addition, we've created our own application for rural candidates. We want to find out people's intent and thoughts about and their background in terms of rural, or what people call rurality, and it is a word we've determined. And also, we want to look at intent or likelihood of people going into primary care. So this is a pre-assessment of people who say they want to go into rural primary care. It gives us data to be able to help make that decision. We have, I'll say quickly too, in addition to the application, or part of that application, we ask the students not only to give us letters of recommendation in terms of academics, but we want 3 letters of recommendation from people in the community where they grew up. So they have to go back to their rural community, talk with a teacher, an employer, somebody in the business, maybe somebody from clergy, and get a recommendation from people in their local communities. The applications that we get then are screened by a committee on the Rockford campus. I'm on that committee along with 3 or 4 other people. We screen the applications to make sure that the people are academically eligible for the program and to go to medical school or to pharmacy school. Then, after we've identified these people, we invite them to the Rockford campus, and they're interviewed, not in the traditional sense of an interview in a medical school or a pharmacy school. Usually you might have a faculty member or 2 faculty members, possibly a current student, who would do the interviews. We have what we call a recruitment and retention committee, R&R. This is composed of 10 to 12 people from across the state of Illinois with rural backgrounds. We have some family doctors, a couple of hospital CEOs, people from the social service sector, and we even have a dairy farmer. And these people are the ones who interview the students and ask them about their primary care and rural intent. We thought we could try to do this, but we're academics. We don't really know, at least anymore, what it's like to be living in these rural communities. So we asked these people to make the decision. So we invite the people up. They're there on our campus for 2.5 days. They interview the candidates who come in, and by the time of the end of the interview, they make the decision as who we should ask to come into our class for that particular year. We accept what they say. We forward that information to the admissions committee on the Chicago campus. No matter how hard we try, we can't get away from the Chicago campus. Inside. The important thing here, though, is that what happened, we've been doing this, again, like I said, for 20 years. And after these 20 years, over 95% of the people who've been recommended by this R&R committee are accepted into the program. So it works very well for us. And again, it gives a community perspective on who it is we're bringing into our particular program. In terms of our learning components, it's important to say that we're a program. All of our pharmacy and medical students take the same curriculum that everybody else would take at the U of I, but then we add on to that. I'll get back to that in just a couple of seconds. We're very experiential. We have our students go into the communities, learn about the communities through all 4 years of their training. Our capstone experience is our 16 to 18-week preceptorship during the 4th year. During that time, our students will live and learn in a rural community for 4 to 4.5 months. They live in the community with the people, and they learn by doing clinical work in the hospital, working with a family physician in the community. And then we also require that our students do a COPC, or community-oriented primary care project during that time. We want them to get a sense of what the community is like and what it's going to be like to treat somebody in a rural area and live in a rural area. We don't want them going into the clinic and waiting for people to come in. We want them to understand what it's like to be in a rural community and what the issues are in rural. So it's what we call a piggyback education. The students are exposed to our rural curriculum, which gives them a specialized experience, a unique training, and better preparation for rural primary care. Just briefly, in terms of the curriculum, it's 4 years. The first year, the students are, as you know, the first year are learning a lot of basic medical sciences. During that year, what we want to do is get them thinking about the big picture. Why did I come to medical school in the first place? Through the first through third years, we meet with the students on a monthly basis in evening seminars and sessions. That first year, again, to get the big picture, we emphasize public health, population-based medicine, and also community health. We, again, want them to think about, why did I come to medical school to begin with? In the second year, we sort of move it back out into the rural community and start talking about what's it going to be like being a doctor in a rural community and treating diabetes, for instance. Or how do you deal with depression and other mental health issues when you're in a rural community as opposed to an urban community? We also talk about topics like community and alternative medicine and what that means for rural people. By year 3, we want the students to start thinking about where they're going to go in that 4th year for that 16 to 18 weeks. So what we'll do is have them pick a community, and I'll show you the list of communities in just a few minutes. But we want them to think about a project they can do in the community once they identify the community, so they start working on their COPC project. We also have them attend the community that they're going to be going to for 2 to 3 days. Go to that community and interview people that are in the community. Talk with a mayor, talk with somebody at the newspaper, go to one of the local businesses, go to the health department. But talk to people and interview people in the community so you get a sense of who these people are, where you're going to be staying for that period of time. We also have them do a windshield analysis. Simply get in the car, drive around the town, and look to see what the town looks like. Where's the hospital? Where are the clinics? Where are the schools? Where are the churches? What's the good side of town? What's the not so good side of town? We want them to get a real good sense of what this is going to be like when they get there for that longer period of time. Then again, in that 4th year, it's our capstone, that long experience in the community. 70% of the time, roughly, is spent on clinical activities, and the other 30% is working on the COPC project. Now, a big challenge for us now is that we have merged this curriculum with the pharmacy students and the medical students. So all of them take all of these courses, or add-on courses, together. We want them to start to learn to work together early on in their education. So they take the seminars together, and at this point, we're sending them out into the communities together. And they'll do their COPC projects as a team, not separately. So our students, again, it's hands-on. We have students when they're out doing this experience, working in camps, and working with young people and serving as mentors and role models for other people in the community. We have what we call the No Harm on the Farm tour, where the students are exposed to agricultural hazards and accidents and health issues on the farm. This is actually one of the local groups volunteers to come in and simulate a rollover, and the students get to see all the people that come in from the rural area and how you deal with something like that in a rural community. We have another thing that we call southern exposure as opposed to northern exposure. We send our students south in a bus, put them all on this bus, and for 2.5 days they're on that bus going to 5 communities in southern Illinois, going to hospitals and clinics, learning about healthcare delivery in different rural areas. It's really nice. They get this exposure on the road. They get to bond. That's our support mechanism here. They're all on this bus together. We even have now Wi-Fi for them, so it makes it a little easier, in addition to the air conditioning. And for the towns and for the communities and the hospitals, this is an excellent opportunity for them to showcase what they have and try to attract the students back to their area in the future. So we're a statewide program for the U of I. We have 25 collaborating rural hospitals in our network, which involves 36 rural teaching physicians and 8 rural teaching pharmacists. The hospitals, we have an MOU with each one of them. They agree to pay for all accommodations, all room and board for the students for the 16 or 14, for the 4-month period. In addition to that, the preceptors don't charge us for their time. This is a win-win situation for all of us. Our students get to learn about healthcare in the community. These people get to showcase what they have at the rural sites. And I can tell you that it really does work. As you go down the line, these students will learn to really enjoy living in these particular communities. And some students, after their 4 months, are walking away almost with a contract in hand to come back and work in that particular community after their residency. This is a map of Illinois. From the top of Illinois, our Rockford is located right in the middle up there in Winnebago County. And from Rockford to the southern tip, it's about a 7-hour drive through Illinois. We have these 25 sites where we have these MOUs. This is where our students can make their selection to where they want to go for that immersion experience. I mentioned the COPC projects. These are community-based, population-focused, and student-centered. We want the students to really pick up something that they're interested in and will follow through on a project. We don't want a report that they bring back to us, hand to us, and we file it away or file it on a computer. We really want people to do something that's meaningful. Over the course of the years, the project categories have been health education, health promotion, access and healthcare utilization, environment and organization of the community, and illness and disease in rural communities. We think COPC makes a difference. Here's a list of some of the types of projects that people have done, working on anything from age-appropriate tasks on the farms, through medical translation for high school Spanish students, barriers to diabetes care, methamphetamines in our backyard. Oh yeah, in Illinois too, I'm telling you. We've got hospice services, and assessing geriatric care as other examples. So, how do you know if you've really grown your own? And that's really what we're trying to do. We're trying to find the people who come from these areas, appreciate the area, and want to move back to that area after their training. What we did is, and you can tell by the gray hair, I've been around since this program started. What we decided when we first put this together was that if anything moved, evaluate it. So anything that we could see that we thought would justify and show the outcomes of the program, we assessed it. So we look at, when students come in, we ask them for their perspectives on community health. When they graduate in the 4th year, we resurvey them again. We also survey students who are not in the program in that 4th year. We evaluate the clerkships, the community projects, but I think what's most important and what's really helped us as we develop our programs and policy for the future is that we keep data on every student who's come into the program. We've now had almost 300 students in the RMed program, and we start with day 1. We find out what high school they went to, what community they came from, have all that in one document. Then we add, when they graduate, we put in where did they go to residency, where did they locate, what did they go into. Midway through residency, which is if they go into family medicine, is going to be in the 2nd year, we survey them again. We call them on the phone. We ask them, where are you going to go next year? Once they go into their residency, after they graduate from residency, go into practice, we call them again. We get the information on practice. And then every 5 years after that, we contact the people. So for all the students who've been in our program, we can account for every one of them through the timeline except one. And I have no idea what happened to him, but everybody else we can tell you something about. So how are we doing after about 20 years? We've had applicants from about 95% of Illinois' rural counties, and as somebody might have mentioned yesterday, for the counties that we don't have an applicant from, it's mainly because there's more deer than people in those particular counties. We've had almost 300 students. 80% of our graduates have gone into or are in primary care residencies. 75% of our graduates in Illinois are in towns of less than 20,000 people. 84% of the graduates in Illinois practice primary care medicine. And 62% of our RMed graduates who are now practicing in Illinois are within 60 miles of where they grew up. This just gives you a little picture of Illinois and how we're starting to populate the state with our graduates. We're really happy to see these little colored-in counties here. We still have a lot more to do, but what we're particularly happy with is when you look at some of these and you see we have 3, 4, and even in one case, 6 of our graduates in one county. We celebrate when our students graduate. After the 4th year, we have a little informal dinner, and they all get John Deere tractors, so they'll remember the experience. So just a couple more things about outcomes. About a year and a half ago, we decided that we wanted to compare our RMed graduates to other University of Illinois College of Medicine graduates who are not in our program. So we gathered data from all the other people who'd been through the program for a period of 11 years, from 1997 to 2007. Developed a database, RMed on one hand, non-RMed on the other hand. And you can see here, just quickly take a look at it, our students are more likely to go into family medicine, primary care, and serve in underserved areas, not in the suburbs of Chicago. I'll get away from that. Overall, if you look at a relative risk comparison, you can see our students are about 6 times more likely than non-RMeds to go into family medicine, about 8.5% more likely to be currently in a rural practice location, and almost 10 times more likely to be serving in an practicing in an underserved area. In terms of years in practice, we've started to look at this over time, and you can see by the legend up there, 160 of our graduates, of the 160, 84 have continuously practiced in a rural location since the completion of their training. And when you average it out, our graduates have been in rural communities for an average of about 8 years. This is what we call success at its best. We were out on the road one day. We're outside of one of the towns. It's a preceptorship site. You look up, and there's a billboard. That billboard is just outside a little town in central Illinois. The 5 people on there, 1 is a preceptor, and the other 4 are graduates of our program. We thought, all right, this is what we want to see. So that's it really for the RMed, and again, we have the R-Farm. We're combining that into Rural Health Professions program. I just want to briefly say, and I know I'm running out of time here, but a couple of things about a couple other programs that we have. We've been developing a Native American Pathway program. We're part of a Kellogg Foundation grant that's focused on developing networks of people with interest in not only rural health, but rural living across the country. And as part of this particular project, we got to talking with other people from other parts of the country who said, you've got this model that's working, seems to be working for rural people. How would it play out with Native Americans? So we took that to heart. We got a little more money from Kellogg and traveled up to Northern California and over to Wyoming to the Wind River Reservation, both very far from where we are in Illinois, and started talking with the people there about the possibility of having Native Americans come through our program with the idea, not that they stay in Illinois, but they relocate back to the reservation. And they're all for it. I don't know how many people, I'm sure you all write grants. Unfortunately, this was an approved but not funded grant so far. We haven't given up yet, but the idea is that we want to set up this pathway, have the students join our rural program, and again, have them come through our program, but in the 4th year, instead of doing that preceptorship in Illinois, they'll go back to the reservation and do the 4 months on the reservation or with the tribe in the local community. What we found, people were telling us, well, they may not want to come to Illinois. That could be true, but what we're really finding is a lot of Native American youth just don't want to leave their homes and their communities and their traditions. So I don't think it's going to be as hard to get them to go back as it is to get them to come with us in the first place. But one thing that this requires, and we don't have it currently in our center, is we need to hire a Native American health education specialist, because we don't understand all the traditions and all the beliefs, but we certainly want to integrate that into our program. So we're working in that direction. I don't have a slide on this because this only happened recently. We are now part of a HRSA-funded grant that's developing a Hispanic Center of Excellence on the Chicago campus, but we're going to be the rural component of that. We're going to target 8 rural communities in Illinois to identify and recruit young people from Hispanic and Latino backgrounds to come into our program as well. That's a 5-year grant. We just started it. These are some of our friends from Wind River. Obviously, this is a two-way street. We went out there. We had them come and visit us, too, so we all get to know each other very well. I'll just throw this in. It's not going to mean anything, probably, but we felt so comfortable on the Arapahoe Reservation that 3 of us were invited afterwards to do a sweat with the Arapahoe, which is not something that happens every day, and I couldn't take it every day, even if it did. We also internationally have, it was about 6 years ago, Princess Naradawa's University, we were approached by the people from the government of Thailand, and they asked us to, if we could replicate what we're doing in the south of Thailand. We started a program there. To make a long story short, the first class of students will be graduating in May 2013, so it's been successful. We have people that we've recruited from that community who will be returning. And finally, we're a member of Network Towards Unity for Health. I'm co-editor of the journal Education for Health for that. I mentioned the MOU with Songkhla in Thailand. We have a similar MOU with Maastricht University. Actually, this is research. And this year, we just started an MOU with Aberdeen, University of Aberdeen in Scotland. So we're into collaboration, rural and primary care. If anybody wants to talk more details at some point, I'd love to do that. And here's our website. Thank you.